Good afternoon. I'm presenting a case of a 50-year-old female who presented with recurrent sneezing and sore throat since 20 years, joint pain of the right hand and wrist since 2 years, lower back pain since 2 years, hair loss since 1 year, skin rashes since 7 months, weight gain of 2.3 kgs in the past 6 days. Her joint pains later progressed to involve the bilateral right and left hand joints, wrists, elbows, shoulders, hip, knees, ankle, and feet. And it was gradual in onset and symmetric. The lower back pain was episodic and non-radiating, and there was no history of trauma, and it was not associated with limitation of movement, night pain, or any hunching. The hair loss was diffuse and not patchy. She had a past history of type 2 diabetes mellitus since 5 years and was on vildagliptin. She had a family history of her mother having asthma and type 2 diabetes. Her father had asthma and her brother has type 2 diabetes. She was non-vegetarian and she had a normal appetite and normal bowel and bladder habits, but she had disturbed sleep since many years. Her OBG history, she attained menopause 6 months ago at 50 years, and she was para 2, living 2, abortion 1, medical termination of pregnancy 1, and both her deliveries were full-term normal deliveries. She had a drug history of taking fluticasone and azelastine nasal spray and antihistamines, and she was a homemaker. Her weight was 66.8 kgs, and she had no peripheral edema or pallor, but she had macular rashes on the face and bilateral upper limbs and lower limbs. Her systemic examination was within normal limits.
Yeah, I think you can hold here. Yeah. See, the clinical presentation, as you could see, she has an allergic diathesis, and also she has quite a good amount of MSK symptoms. So, what are the possible differential diagnoses?
Go back to the history, it will be easier to see. The first slide, history. Because there are no systemic findings, so the history is all important. The first slide, chief complaint.
Yep.
Long-standing allergic diathesis and recent onset joint pains.
So, I think if you follow put it into single basket, it's a...
Is it only the allergic symptom confined to upper airway? Was there any history of wheezing or any evidence of asthma, treatment for asthma?
No.
Only the family history was there.
Yeah, there was a family history of asthma, but she had no history of asthma.
To say extras, and there should have been previous history of chronic wheeze also should have been there. Never had that. So no neurological symptoms, peripheral neuritis picture or anything. Just a musculoskeletal symptoms and allergic upper airway disease.
And any description about skin rash? I mean, did you expand the skin rash?
Macular skin rash.
Persistent?
Transient.
Itchy? Not sure. Like if it's an itchy rash, itchy transient rash, it could be an urticaria. So it could fit into the allergy basket. Like patient has an urticaria and recurrent sneezing and sore throat for 20 years. And musculoskeletal pain also, did she have any joint swellings?
No.
Any restriction of movements?
No.
So it is more arthralgias. So arthralgia always has got a much wider differential diagnosis. Aches and pains are common with almost every systemic disease, including diabetes, endocrine diseases, viral diseases, fibromyalgia, depression. Everything can cause musculoskeletal pains. If there's a swelling and restriction of movements, then we would narrow it towards an arthritis. If it becomes arthritis, there is only X number of diseases which can cause arthritis. So the dominant feature, I would think, that is a chronic nasal allergy and maybe a oropharyngeal allergy. And hair fall, I don't know how much importance to give, and we need to quantify it generally. If you ask any woman around menopause, would have invariably hair fall because of the menopause reason itself, age itself, and iron deficiency may not be uncommon in this age group. So hair fall is again very common unless you quantify, like she has become significantly, her very long hair which should come up to the hip level, it has come to this level, or she loses 200, 300 hairs per day, or when she sees hair everywhere in her house or all over the beddings, then we have to give weightage to it. Otherwise, hair loss is a common symptoms. Oral ulcer is a common symptoms. So when we evaluate connective tissue disease like lupus, if you ask a blanket question, do you have a hair fall to a young girl? I'm sure 80% will say yes. And if you say oral ulcer, most of us will say yes, because you would have had bitten something would have burnt our mouth, and it's very common. And joint pains, yes, if you have clicked, and if ANA comes positive, she may fit into the criteria of lupus, but we have not specifically clarified whether the oral ulcer is attributable to lupus, whether hair fall is attributable to lupus. So that is a fallacy sometimes we need to overcome. Do you have more information now?
A few things which you have to keep also consider is the weight gain and a few other changes.
Within
Yes.
6 days.
Yes.
6 days it says.
She puts it actually, but I think it's
It's
overall.
a recent weight gain.
Weight gain. You
She
can
must
put it
have measured it before 6 days. That could be one reason.
Yeah, yeah.
And so, one disease which can link weight gain and hair loss? Very good, very good. That's the one thing, yes.
So in this case, actually, see, we need to seriously first consider non-rheumatological causes. And one possibility, there is an allergy which is pre-existing from past 20 years with a strong family history of mother having allergic diathesis. So the one possibility, the entire symptom could be attributable and put to allergy or allergic diathesis. The second possibility is she's a diabetic of more than 5 years. The diabetes per se, if it is not under a good control, can produce a lot of MSK symptoms. So also the weight gain or loss, either direction things can happen. So it could be a non-rheumatological diabetic associated or an endocrine associated arthralgia or arthropathies, MSK symptoms. The third still remote possibility, she is a 50-year-old female with an arthralgia arthritis. Of course, the symptoms are not too specific to call it as inflammatory. A remote possibility of rheumatological diseases, including rheumatoid as the early manifestations. It's a vague manifestations could be considered. So these are the three possibilities with which we started working it up. One, allergic diathesis, the possible endocrinal or metabolic disease. The third possibility was the rheumatological condition. That was the remote possible differentials that we had.
Did you get a little more history on low back pain? When you listen to low back pain, apart from what you mentioned, there's something called inflammatory low back pain. Can anyone tell me what is inflammatory low back pain? Some abbreviations we use is IBP, but forget abbreviations. Inflammatory back pain is not the same as mechanical back pain. From what you have written, it is doesn't look to be mechanical. There's no aggravating relieving factors. It's a bit odd. There's nothing which makes her back pain worse. Okay, what is inflammatory back pain? Would it give you a clue to a diagnosis? Or arthritis and back pain around the same time? So could it point to a rheumatological diagnosis? Early morning stiffness. Any back pain more than 3 months with early morning stiffness, we call it, and relieved with activity, we call it inflammatory back pain. So it's good to, when you give a history, to say whether it's inflammatory or non-inflammatory. So
what she has mentioned looked like it is non-inflammatory. It's a constant pain. So this type of pain, I would probably go towards a chronic pain syndrome, chronic persistent pain. And she has a back pain and pain in the joints. So I would think whether it is either endocrine related aches and pains or fibromyalgia like chronic pain syndromes. So from musculoskeletal point of view, probably very difficult to connect wheezing. One rheumatic disease which can connect easily allergy, nasal allergy, asthma with rheumatological syndrome is eosinophilic polyangiitis, or what used to be called as Chokes-Strauss syndrome, which can sometimes present as arthritis, though more common presentation is like vasculitis and cardiac involvement, etc. Go ahead if you have any presentation.
allergic diathesis. So initial lab tests showed a CRP of 6.71. Rheumatoid factor was negative, ANA was negative, anti-CCP was negative, C3 and C4 were normal, and serum IgE was normal, and TSH was 3.95. So we went on to anti-TPO, which was 201.5, which is elevated, and anti-TG, which was normal. HLA-B27 was negative. So the final diagnosis is Hashimoto thyroiditis. She was started on hydroxychloroquine 200 mg, Lizalostein 10 mg, calcium vitamin D supplements, and celecoxib SOS. On follow-up 1 month later, there were no rashes, but she complained of swelling of eyelids and red eyes on and off, and white discharge per vagina. At this time, her CRP was normal, ESR was normal, but her TSH was elevated at 10.42. So she was advised to take thyroxine 12.5 microgram, and she was also referred to a gynecologist and ophthalmologist. 2.5 months later, she had stopped all the medication since 15 days, and she had a recurrence of her itching, but no rashes or myalgia. Her CRP was normal, her ESR was normal, but her TSH was borderline 4.51. So she was advised to restart all medications and increase the thyroxine to 25 microgram. Her symptoms subsequently subsided.
So I think this is a scenario where it's what really was happening was something else, and what was obvious was different, because it was Hashimoto thyroiditis which was clinically presenting. That weight gain was there, but somehow in the initial you will have either a sick euthyroid status or a normal euthyroid status, which keeps fluctuating, and that's where the difficulty comes, because in the first instance her TSH was normal, so we didn't introduce her on the thyroid replacement. It was only because the rashes were not explainable, we went ahead to use anti-TPO, anti-TG as one another marker, because that's what we thought it could be, because she is 50 years. It's an age where we expect Hashimoto thyroid to be more commoner. And her other clinical presentations like weight gain was possibility. We were thinking it could be thyroid or hypothyroid. That put us to take anti-TPO and anti-TG. And as a routine where immunoglobulin E is normal, C3, C4 are normal. If the patient has a papillosquamous urticarial rashes responsive to antihistamine, even the advisory of how to evaluate suggests to get anti-TPO and anti-TG. And when we did it, those two were positive and gave the clue that what we are dealing with is an Hashimoto thyroiditis. And the treatment was quite obvious. She took the medicine, doing good, dropped the medicine. She made a trial of herself that this is the drug which was working for her. And we reintroduced the drug, with this time with even TSH being elevated. In the next 2-3 months, her disease settled down.
So probably the only drug she can be discontinued later is hydroxychloroquine?
Hydroxychloroquine, yes.
Yeah, this case is a very good illustration of non-rheumatological cause for musculoskeletal symptoms, and hair fall, probably musculoskeletal, because musculoskeletal has improved with the thyroid replacement. If it has not improved, persisted, then I would think of a chronic pain syndromes, and she had improved, and probably she has two different diseases. She has a chronic nasal allergy and Hashimoto's thyroiditis, and going on to develop hypothyroidism, and many of her symptoms could be explained by that, and symptoms resolved with the appropriate replacement therapy. So this is an illustration that rheumatic diseases have multiple differential diagnoses, and we should, as a person who deals with musculoskeletal aches and pains, don't rely only on the test. If the patient has got low titer rheumatoid factor positivity, like rheumatoid cutoff is 20, and if the result has come out 22, sometimes we think that's rheumatoid arthritis because we are relying on the test. And the clinical features are not arthritis, it is arthralgias, and low titer rheumatoid factor probably could ignore and look for other causes. So this kind of a patients illustrate the importance of relying more on the patient story and catering your investigations according to the patient's symptoms, then you arrive at the diagnosis. Otherwise, if you blanketly do all the tests, something will come positive, then becomes difficult to interpret. And even if something comes positive, then interpret it in the context rather than giving weightage to autoimmune rheumatic diseases test. But to be frank, one of the least, what should I say, paisa vasool type of test in medicine is rheumatological test. Like if you are suspecting diabetes, we do sugars are 200, HbA1c is 6.6. Sure shot, 100%, there is no other differential diagnosis. And if you suspect any infection, an appropriate test comes, if you suspect infectious mononucleus, you've done a Paul Bunel, comes positive, it's a definite answer there. But if you have musculoskeletal aches and pains, and if you do all the rheumatic, something comes positive, still there are many, many differential diagnoses, because even rheumatoid factor test can be positive in about 20, 30 diseases. ANA can be positive in 30, 40 diseases. So it is very, very broad spectrum test. So you should not be relying on the test to make a diagnosis. Interpret the test in the context.
What was the ANA in this patient?
Negative.
So you won't be surprised, in ANA can come positive in autoimmune thyroiditis. Up to 40% of patients may have positive. So probably we would have gone another track if we saw the ANA. But that's what sir was saying. Come back to the track. If you look at the whole picture, ANA is just a bystander here. It's just no autoantibody positive in association with autoimmune hypothyroidism.
In Hashimoto thyroid diseases, the reported ANA positivity is somewhere around 15 to 20%, which is higher than the normal population. Yeah, please go ahead.
Confirm the Hashimoto's thyroiditis. Did you do a FNSC or a biopsy, and was there a goiter in this patient?
There was no obvious goiter in the patient. The only thing is there was quite a confusing swelling. It's very difficult to attribute to that. Almost she was euthyroid, so there was nothing to suggest from the blood test at the first point that there was. As I said, as a routine in an papillosquamous rashes with IgE normal, histamine responsive, if all the other tests comes out negative, it's best to exclude a possibility of Hashimoto thyroid, because that's one of the commonest. I think she will discuss the literature that's available with reference to Hashimoto's. Yeah,
FNS, to confirm Hashimoto's, you don't need a FNAC. Autoimmune thyroid, Hashimoto's antibody can be present even in the absence of an obvious swelling. If you do an ultrasound, you might pick up very subtle changes in, and if you do an FNAC, it can be useful. But to confirm Hashimoto's, I don't think you need to do an FNAC.
Yeah.
Either on an FN or a biopsy, then we call it as Hashimoto's
Yeah. We are using this term interchangeably. Autoimmune thyroiditis.
Talking of autoimmune, which could be other forms of lymphocytic thyroiditis also.
Yes.
Called as autoimmune
If you have a goiter presentation, then you would require an FNAC to confirm whether it is autoimmune thyroiditis. When you have an urticaria type presentation, sometimes recurrent pregnancy loss, we do anti-TPO. And there women don't have any thyroid related symptoms at all. The anti-TPO is strongly positive. That it can be one of the reasons why a woman is having recurrent pregnancy loss. So that kind of situation, I don't think you need to do if you are curious, you can do an ultrasound thyroid. You would see some changes there. But I don't think it is required to make a diagnosis. If TSH comes down, if TSH changes, you treat it as either as a hypo or hyper, depends upon the stage of thyroiditis.
Now, when it comes to the literature, I think
You have any more presentation?
if you speak from the literature perspective, to call it as Hashimoto's, the literature insists that the FNAC and the biopsy proof is a must. But of late, with the anti-TPO, anti-TG being available, now they have little reviewed the criteria. In the reviewed criteria, the FNAC or biopsy proof is not required. Patient should have a thyroid alteration with positive anti-TPO, anti-TG. So earlier, if you look back to the literature, what you said is correct. To call it as a designated Hashimoto thyroiditis, histopathological proof of a typical infiltration with Hurtell cells were all recommended. Down the lane for an early diagnosis, now because of the early diagnosis being the prompt, biopsy is not being mandatory, because you may not get every time, and the point where we put the needle for FNAC or anything, we may not hit the needle place where the things are there. Yeah.
Basically, it is autoimmune thyroiditis and not Hashimoto's thyroiditis. That difference, I think. And that's what probably he is
Yes, yes, yes. I agree fully with that. No,
Not specifically Hashimoto's thyroid.
Yes, agree.
right.
Go ahead.
Go ahead.
If you have any slides, please present.
That's true. End game is that. If you want to report, if I report this case, they would have asked me, the reviewer will send me one review comment saying that, what is the FNAC report?
Autoimmune hypothyroidism can present as early Hashimoto or Goiter's thyroiditis, or at a later stage as atrophic thyroiditis. The female to male ratio is 10:1, and the age of diagnosis of women is usually 30 to 50 years. HLA-DR polymorphisms are the best documented genetic risk factor, and CTLA4 is a weakly associated risk factor. Hashimoto thyroiditis can present with extrathyroidal manifestations, including chest pain, fibrositis, rheumatoid arthritis-like presentation, and it's associated with vitiligo, hives, alopecia, primary and secondary Sjogren's syndrome, relapsing steroid-responsive encephalopathy, steroid-responsive lymphocytic interstitial pneumonitis.
Thank you for your nice